What's up, y'all? I am back. I'm Dr. James Hall, and I am a nephrologist. I've been practicing for about 20 years, and today we're going to talk about how to adjust medicines with chronic kidney disease, patients with renal failure. What do you do as a primary provider to make sure you don't cause any damage or harm to your patient? First thing you need to do is look at the GFR when you get a patient. If their creatinine is normal, that doesn't necessarily mean that their GFR is normal. Hello, hello. A normal creatinine is not synonymous with normal renal function. Why? Because things like age, things like muscle mass, things like rate of metabolism, all these factors play into what's actually happening with your patients. So a 65-year-old Caucasian lady with a normal creatinine is not going to have a normal GFR. That's why they report the GFRs on labs now, because the GFR, the glomerular filtration rate, is synonymous with the creatinine clearance. So that's something that you have to look at when you're prescribing medications on your patients. As a nephrologist, it's kind of a knee-jerk reflex for me, but as a primary provider who's busy trying to check everything, blood pressure, diabetes, cholesterol, they got an ingrown toenail, they got a sore throat, and then right when they get ready to go out the door, they say they got chest pain. Trust me, I've had them. I worked in the emergency room, worked in hospitals, and right when they get ready to leave, you got all your everything ready for them to go, oh, let me tell you about this chest pain I've been having. So, when you get your patients in and you get ready to prescribe a medication, this is what you need to do to quickly bridge that gap and knowing how to manage, how to adjust these medicines. You look at the GFR. The second thing you do, you look at the category of medication that it's in. A big category is antibiotics. Most antibiotics are cleared by the kidneys, so you need to look at that GFR and adjust that antibiotic based on the GFR. A good rule of thumb is to cut it in half. A lot of times what I would do, if it's a patient with a severe infection, for instance, I had a patient a week ago with VRE. VRE, vancomycin resistant enterococcus. And he was a dialysis patient. Technically, he should get Cubicin, 500 milligrams, Q48 hours, but his infection was pretty severe, so I put him on 500 milligrams every day. So sometimes it depends on the infection, but in most cases in the outpatient setting, you can cut the antibiotic in half, and usually that's a good rule of thumb. But you can always look it up. You got your pharmacopoeias, your PDRs, you got Dr. Google. Dr. Google got a PhD, an MD, and any other kind of D. So you can pull it up on Google sometimes and find it. Up to Date is a really good resource to help you know what medicines to adjust. NSAIDs, people with a GFR below 30 milliliters per minute, I try my best to never give those patients NSAIDs, especially if the patient's older. NSAIDs we know are directly tubular toxic. They cause afferent arterial vasoconstriction, and they are toxic to your proximal tubules and your distal tubules. So you have to keep that in mind starting this class of drugs. Your Celebrex, your Vicodin, your Motrin, your Aleve, your Mobic, Toradol, Ketorolac. I mean, this class is extensive, so always watch the GFR when you start this class of medications. Always look at the patient's age, because older patients can't really metabolize those drugs like a younger patient can. And like the 65-year-old lady I told you about earlier, her GFR is not going to be normal just because she has a normal creatinine. So gout medicines, allopurinol, that's one of the ones we drop in half in our CKD populations. Neurontin, gabapentin, that's another one that we always cut in half, or we give it less frequently in CKD patients. Allegra, we always use half the dose in that medicine. Zantac is another one. Uh, a big one that I know you guys use a lot is diuretics. Diuretics don't work the same in all patients. So you look at their GFR, and some patients actually need a higher dose of diuretics if they have chronic kidney disease. So this is a kind of an outlier. Most patients, we cut back on the dose when they have kidney disease, but patients who need diuretics and have a compromised GFR, they need more diuretics because their kidneys aren't working as good. For example, if a CKD4 patient come in volume overloaded, CHF, acute pulmonary edema, my go-to dose of Lasix is 100 milligrams IV every 8 hours. That's my starting dose. I don't start with 20 or 40 or 60 like you see some of the ER doctors do. I start with 100. Sometimes I'll give 200 milligrams of Lasix IV as an initial loading dose or bolus dose. And I know you think, man, that's a big dose. It is. And ototoxicity is a risk with giving Lasix, but I've never seen it in my patient population. And I never heard patients talk about it. Forgive the pun. But, you know, Lasix is one of those drugs that's dose dependent. So if you give too little, it's like you're giving candy. So you want to make sure you give enough of the drug to actually work and actually do what you want it to do. Hypoglycemic medications. These medications traditionally have an extended half-life in patients with CKD. So you always want to watch for this. You don't want to have a patient, waking up at 2 in the morning with a sugar of 30 and risk having a hypoglycemic coma or a major neurological event from a medication that you gave because you were not aware of the side effects. So keep in mind, all medications can potentially cause harm. So when you put a patient on medications, think about what's the GFR. What's the GFR? This doesn't take a lot of time. I know you guys are busy, but you can quickly come to that conclusion. Let's try half the dose. Have your patient recheck their sugars in 2 or 3 days. If it's still not controlled, you can go up to the standard therapeutic starting dose. That's what I normally do. I've had countless patients come in with hypoglycemia requiring IV dextrose for 3 days, 4 days, just to get their sugar up to 100. Pain medications. These medications are cleared by the kidneys and sometimes by the liver. So if you have a compromised GFR, remember to try to cut back on that dose of morphine or some of your IV pain medications because they are cleared by the kidneys sometimes too. Digoxin. I've seen patients come in with dish toxicity. They were put on a normal standard starting dose of digoxin and nobody considered their GFR. The patient came in with first degree AV block, bradycardia, about to die. We all run around the place trying to figure out what to do, and nobody considered the patient's GFR. Nobody considered how long is the half-life of this medicine, given the fact that the patient only has a renal function of 30. So that's the kind of thought process you got to think when you start medications. Start low, go slow is a good rule of thumb. Cutting the dose in half is also another good rule of thumb. Another medication is lithium. Lithium is a common agent used for psychotic events, and it can cause a multitude of renal issues. It can cause renal fibrosis. It can cause nephrogenic diabetes insipidus and renal failure, AKI. So by all means, start that drug at a low dose. And there are some newer antipsychotics that you probably should try before going to lithium. That's what I've been seeing most of their psychiatrists using lithium as a last resort type antipsychotic. The other thing that a lot of people don't know about adjusting medications is your beta blockers. Beta blockers are cleared in the kidney if they're of the hydrophilic category. There's hydrophobic and hydrophilic. The hydrophilic beta blockers include your atenolol, bisoprolol, nadolol, and acebutolol. those 4 are cleared in the kidneys, and they have a longer half-life if you have chronic kidney disease. So, atenolol is one that people in this area where I live use a lot, and I've seen severe bradycardia in a patient with CKD who was placed on atenolol. So that medicine, really watch for bradycardia when you start that medication on your patients, if they have CKD or if they're on dialysis. It's a great drug. I love it. But bradycardia is a major risk factor with that drug in renal patients. So I hope this video was helpful to you. My job is to try to bridge the gap from medical knowledge to clinical application. I want to use my YouTube program to try to teach you guys, primary providers, first responders, so to speak, how to manage kidney disease in the primary care setting. I feel like our course that we've created is like a mini fellowship. There's also a free webinar that you can check out that has a lot of cases, and it'll talk about things like this, things that you encounter in your clinic that you want to know, how can I quickly decide what to do with this patient who has renal problems? Or how can I manage this patient if I can't get them to a nephrologist in a year or 6 months? That's a long time to wait to see a nephrologist. So I encourage you to check all that out, and I hope to see you in the next video. Thank you. Goodbye. Send me questions about what you want to talk about. I will answer any and all questions that you have about how to manage your CKD patients, and I look forward to hearing from you. Appreciate it. Bye.